in the picture as the focus. So what we are trying to say that, along with that, the lines is a major concept, procedures is a major, and I already mentioned the research. So please understand the focus is the backbone for most of the organs in day-to-day practice. To understand for any pediatrician about the focus, you need to understand that ultrasound beams, they are enemy for the air. As we know, the tissue looks like a gray, while the fluid is the best friend, which is classic anechoic area, while the bone is echogenic material. That's a basic, very, very basic understanding. And then we'll go forward because I'll be showing a lot of videos. I'll be showing a lot of pictures to you guys. They'll understand. This is the common case or the gift of a God to India. All we struggle. Outborn babies, roughly 32, 34 weaker, 1.4 kg. Baby was in the outside hospital and then deteriorated. Apnea, bradycardia, desaturations, hyperglycemia, ventilation, hypotension, poor perfusion, acidosis, high lactate. You know the diagnosis. You know the diagnosis, most likely gram-negative sepsis. You also know that most likely organisms. From this aspect, we started the research on this area. So what we saw the functional echocardiography in this baby. We saw the functional echocardiography was these babies have basically, you can see this is severe TRJ and the pulmonary pressures ranging up to 50, 60. So what we saw in the Indian gram-negative sepsis babies, which are late onset sepsis babies, we saw the regurgitant murmurs. And those are part of secondary pulmonary hypertension. And that's what we published in Italian Journal of Ultrasound as the gram-negative sepsis, which is the late onset, which has a late, basically the secondary pulmonary hypertension. And that's a paper published by one of our DM candidate along with one of the faculty, as the pulmonary pressures were high in those babies who have a late onset sepsis. We also documented from the echo that the cardiac output in these babies were quite high. The normal cardiac output is 150 to 250 ml per kg per minute. This cardiac output has jumped to 300, 400, 500 ml per kg per minute. So one side we're talking about pulmonary hypertension, one side we're talking about the high cardiac output, which also we published way back in 2015 as the cardiac output is high in late onset neonatal sepsis. So we know the hypotension, we know the high cardiac output, we know the pulmonary hypertension, secondary pulmonary hypertension. So if you go back to the basic formula of a blood pressure, which is cardiac output and SVR. So we have a gram-negative sepsis, we have a hypotension, and we have a high cardiac output. So from this angle, what we saw that these babies of hypotension have a high cardiac output, and this high cardiac output is associated with, naturally, with the formula as a vasodilatory shock. So what we are trying to say that hypotensive shock in the gram-negative sepsis from the hemodynamics monitoring is mainly warm shock, mainly vasodilatory shock. That's the first thought process which we documented from the various articles. We gone one step ahead. One of our DM candidate, Dr. Arshadi, we have documented ventricular functions in those babies. And those ventricular functions, we found out that they have a biventricular dysfunction in those babies. In the later stages, or the bad shape, when the baby comes in bad shape as a multi-organ failure, they also have a biventricular dysfunction. So I told you hypotension, I told you pulmonary hypertension, I told you high cardiac output, I told you vasodilatory shock, I told you ventricular dysfunction. The last year, we also documented MPI, which is one of the important marker of the global ventricular function. And what we found out that these babies have a global ventricular dysfunction on the basis of the tissue Doppler, on the basis of MPI. So this is what we are talking as a gram-negative late onset neonatal sepsis in India. We also documented, which we have various case reports in BMJ, that these babies have a third space leak. This is a classic pericardial effusion. This is a pleural effusion. And this is what we are talking as ascites. So The gram-negative sepsis in babies have a third space loss. That's what we are talking. So one side we are talking as the septic shock in India, which is a warm shock, which is associated with the hypotension, high cardiac output, vasodilatatory shock. We also mentioned about the secondary pulmonary hypertension. We also mentioned about the third space loss, and we also mentioned about the myocardial dysfunction. This is the hemodynamics, what we published in various journals, and we came out with this flowchart that the late onset, most of them, I'm not talking all, most of them, gram-negative, late onset sepsis is a warm shock, what we are dealing in Indian setups, especially in the government setups, especially in the medical schools, where we are getting outbound babies a lot. It is a very common practice in day-to-day to have these babies on dopamine, dobutamine. And these are the vasopressors available. We have dopamine, adrenaline, noradrenaline, vasopressin. So what we started as a physiology, if you go back to a pharmacology book, we know that dopamine has alpha and beta receptor, alpha and alpha 2, beta and beta 2. Excellent to improve the blood pressure. Excellent to improve the blood pressure. Excellent for heart. But unfortunately, it also increases the pulmonary hypertension. So one side we are talking about late onset sepsis, pulmonary hypertension, and dopamine will enhance that pulmonary hypertension. Hence, we have stopped the dopamine in my unit in the last 15 years. What about epinephrine? Wonderful for vasopressor, wonderful for heart. So this is a good drug. So we can think about this drug in this late onset sepsis, no action on the pulmonary vessels. What about noradrenaline? I'll come to this discussion. This is a drug which is used very commonly in adult practice and PICU. Excellent for increasing the pulmonary, basically the vasopressor. No action on the heart. This drug has also nice action of a decreasing, various animal studies have shown decreasing pulmonary vascular resistance. So one side improves the blood pressure, one side decreases the pulmonary vascular resistance. That's one of the good aspects of this drug. So this is in my list. What about the vasopressin? A lot of people don't use. It's a reserve drug, but excellent for SVR. Excellent also for decreasing PVR. And that's what we saw in sepsis. These babies have pulmonary hypertension. No action on the heart. So I have 4 vasopressors: dopamine, adrenaline, noradrenaline, vasopressin. Dopamine I'm not using. Vasopressin I reserve. So we do play nowadays with adrenaline, noradrenaline. I'll come to that point. What about the dobutamine? Dobutamine, no actions on the blood pressure. It has mainly the inotropic action. Milrinone, as we all know, it has the effect on PVR. It has effect on the heart. Side effect is SVR. That's about the milrinone. So that's on this basis, one of our DM candidates had studied noradrenaline in neonatal septic shock. And that was published in Journal of Tropical Pediatrics. And what we saw that wonderful drug to improve the blood pressure, to improve the vasopressor, to improve the blood pressure and pulmonary hypertension with improved OI. One more candidate, one of our DM candidate, Dr. Rima, has compared adrenaline and noradrenaline. And that has turned out that, okay, we accept both these drugs. And that's what is happening in our unit now. We are currently using this drug. We've gone one step ahead and we have used the milrinone along with vasopressor because of the ventricular dysfunction. And that article is in progress now. And we saw that you improve the blood pressure by vasopressor and you improve the ventricular functions by this inodilator. So one side I'm using vasopressor, one side I'm using inodilator. This is the book chapter we have written. This is the book chapter we have written into a book, as you all know, neonatal hemodynamics book by the Professor Martin Cloquot and Patrick McManra, hemodynamics in resource limited settings. So in this chapter, what we mentioned, septic shock usually has a high cardiac output with low systemic vascular resistance, which is warm shock with pulmonary hypertension. Hence, first line treatment is volume plus vasopressor. And we consider noradrenaline over the epinephrine or dopamine as the vasopressor for a choice because of the good effect of vasopressor and beneficial effect of pulmonary vascular resistance. And this is what in developing countries we are working in day-to-day practice. So going back to the first chart, as a warm shock, we are talking about the pulmonary hypertension. For pulmonary hypertension, we are talking about the melanin or some effect of noradrenaline. We are talking about the hypotension, adrenaline or noradrenaline. We are talking about myocardial dysfunction with melanin or dobutamine, and we are talking volume as usual. So see the hemodynamics, how has changed thought process in my own unit. I'm talking about my data. I'm talking about my unit. It might be not applicable to all centers. You need to have your own data. You need to find out your own situations, what type of bugs you are dealing. But this is by and large, I'm talking about the gram-negative late onset sepsis. So we did Indian survey and published in Frontiers in Pediatrics. And we saw that still a lot of units are using dopamine. Still lots of units are in dobutamine. Few units have started using adrenaline, noradrenaline now, very rarely vasopressin. So this is what current scenario, which is ongoing at present moment. This is what the last year we published as NNF guidelines, as a CPG guidelines, as along with Dr. Veera and the Kiran, the hydrocortisone in septic shock. So nowadays we don't wait hydrocortisone for a lot of time. Once one vasopressor is failed, we immediately give the hydrocortisone. And that's what we are getting better results now. Volume, one vasopressor, whatever the choice of your unit, and then hydrocortisone. So it has a better outcomes in a septic shock. Now let's see, we saw the functional hemodynamics. So we saw the hemodynamics. Let's concentrate on the brain and lung about those babies. This is a classic normal lung ultrasound, as you all know about A lines. But in this baby, you can see this is abnormal baby with hepatization, air bronchogram, and Schreier sign. This is a classic pneumonia. Those who are interested, this is the article written by our team, lung ultrasound to assess the severity of pneumonia. You can go through that. It's a pre-article in PubMed. So pneumonia is very easy to diagnose by lung ultrasound. You can see the wonderful brain ultrasound. Again, brain is so easy to diagnose this baby with a meningitis and ventriculitis, dilated ventricles. You can see the rainy particles inside. You can see the echogenic boundaries inside. And again, that's the article. You can go through that, written by our team, that ultrasound and sepsis and the CNS work on that. This is the baby, which is the ventriculitis. But by doing Doppler, I know the pulmonary pressures are high. Once I put a pressure, the Dopplers are reversed. So this baby is a candidate for shunt. Once I control the protein, this baby requires the shunt therapy. So prognosis, diagnostic, therapeutic. That's the role of PROCUS, which I'm trying to tell you in those parameters. This is another baby which came from outside, fever for 7 days, and turned out to be this brain abscess, rare organism, Burkholderia. It's published in Indian Journal of Pediatrics. This is another baby which is deteriorated. Came on day 1, means day 7 of life, and immediately we saw this echogenic foci. And this echogenic foci turned out to be liquefaction and later on nice abscess. So this is how the brain ultrasound helps us to diagnose the brain abscess. This turned out to be Acinetobacter. This is day 1, this is day 2 of admission. That means day 7, day 8, and day 15. See the role of serial ultrasound to see the brain abscess. This is another baby from outborn. You can see the subdural collection, classic subdural collection with the particles inside, turned out to be E. coli. This is the baby which presented with sepsis. This is from Dr. Sachin Verma from Lucknow. You see the echogenicity here in the cranial and sagittal views, and at 1 month, encephalomalacia. This is Enterobacter. So you might miss these things if you don't do the cranial ultrasound. A lot of time people are afraid of doing CSF because baby is sick. Do the ultimately ultrasound, you'll get the findings. This is the baby with echogenicities, and those echogenicities turned out to be, see, this turned out to be the encephalomalacia. That's the classic pictures of the sepsis. One of our another DM candidate did the Dopplers in anterocerebral artery. And what we documented that once your RI is reversed, outcomes are bad. and that's published in Journal of Neonatology. So RI guides you about the prognosis in those babies. Another DM candidate, Dr. Pari, has documented about the renal Doppler, about the gut Doppler, and predicted the neck and AKI. So in sepsis, if the Dopplers are absent or reversed, those babies with the gram-negative sepsis are prone for NAC or AKI. And that's what the role of the Doppler in septic shock. This is from Dr. Bujata from Andhra. You can see this baby came with the shock. If you don't do the echo, you will not find out this pyopericardium. You will see this is another baby from Dr. Sachin Verma. This is the classic septations, and this is the baby with the MRSA. So this is a pus in the pericardium. You see another baby here. Just watch this vegetations. These are impacto endocarditis, MRSA. So that's the role of a picking sepsis in day-to-day practice. These are the babies with a gut ultrasound. You can see the increased blood supply, ring pattern, zebra pattern, Y pattern, or decreased blood flow. These are the classic pictures. Again, you can go through this article written by Dr. Chinmay, one of the ODM candidate, that POCUS helps in checking the gut ultrasound, and you will be able to find out wonderful nematocysts. These are the nematocysts. These are the nematocysts. You can see, watch here, these white dots moving. These white dots in the liver ultrasound are nothing but portal vein gas. This is a pneumoperitoneum. That's the ascites, which is a complex ascites. So all the features of a gram-negative sepsis leading to NAC, you can pick up by gut ultrasound. So we discuss about the heart, we discuss about the brain, we discuss about the lung, we discuss about the gut. So many useful things. Similarly, you can see this gut with the septations inside. That's a liver. These are the septations. This is a complex ascites. This is because of the Klebsiella. Now, recently, we have gone one step ahead, and we have diagnosing and utilizing a lot of liver ultrasound. This is classic liver abscess. And this is last year only, utility of POCUS as the liver ultrasound. And I'm proud to say that this is the first article in the world quoting about neonatal liver POCUS and sepsis and use of POCUS in and liver for that one. So go through that. It is very simple, it is useful. You can see the abscess, liver abscess can be picked up very easily. This is you can see the particles, pyelonephritis. These are the dilated pelvis with the particles. These babies, again, a septic shock. So at every level, you can pick up, you can add the diagnosis. This is the baby with basically the knee joint with the effusion. This is the effusion of the knee joint. And that's the septic arthritis because of MRSA. This is the abscess developed after giving the hepatitis B vaccine. Very simple. Large mass, liquefaction inside. That is what you can able to see. Always a lot of babies of septic shock requires intubation. You can confirm that intubation by ETT tube position by the POCUS. So we documented one nice thing, that does POCUS helps in sepsis? POCUS is abnormal in 40% of the brain, 80% in heart, 30% in lung, 10% in abdomen. So that's we published in Journal of Neonatology. Yes, it is so useful in day-to-day practice. So one case I showed you, lots of hemodynamics I mentioned, that's the research. Lots of management protocol I mentioned, that's all research. And a lot of organs I have shown you. One case of warm shock with associated problems. That's what we discussed as various research. This is all documentation. This is all research, which I'm trying to tell you. Our own research helps. Now it is time to talk our own research rather than talking the Western research, rather than talking the research from the various other people. We all need to put our own data. That is what I'm trying to tell you. So if you see the additional data about the brain ultrasound, this is a classic echogenicity of meningitis. This is a classic increased blood flow in meningitis. These are the septations which are classic of chronic ventriculitis. Once I see this brain ultrasound, this baby requires long-term 6 to 8 weeks of therapy in future might be efficient. This is the baby with hypoglycemia and chorioamnionitis. And 1 month you can see this encephalomalacia. So chorioamnionitis monitoring is also important. A lot of time we don't do the ultrasound before discharge, but this is a prognostic. This is useful. You can see the posterior part, occipital lobe. That's what is gone. This is a classic baby, which is 24-weeker twins. Immediately born with this one. We all thought, baby born at 6 o'clock, we thought this is a gram-negative septic shock or necrotizing fasciitis. Usually I start around at 7 o'clock and I did the brain ultrasound. And this brain ultrasound shows these echogenic balls. These echogenic balls are nothing but fungal balls. Immediately diagnosed as a congenital candidiasis. Started immediately therapeutic dose. And we got result candida at 3 days. So we could able to save these babies because of these immediate diagnosis. You can see other babies with the confirmation. These are the candida fungal balls. These are the various balls. Not only the balls, you can able to diagnose the abscess. These are the outborn babies. Lot of babies getting outborn. Lot of NICUs are there outborn. And there is overuse of antibiotics, TPN, ventilation. See this correlation of MRI, this baby. These are the candida abscess. This baby, I have never seen so many abscesses in my life. You can just watch so much abscesses all over the brain parenchyma. So this is what you can pick up by brain ultrasound, confirm with the MRI. That's useful. We also did hemodynamics in the fungus, and we found out that the right ventricular affects more in the fungal infection. This article is in pipeline now, that right ventricle functions are more affected as compared to the left ventricle. They are also there, but then bilateral fungal disorder. You can see the kidney, this kidney with these whites, these are nothing but the fungal balls in the kidney. And the kidney is the one organ which you usually get immediately. Not only the bacterial and fungal infection in the brain, but you can pick up this calcification. These are the periventricular calcifications. This is the lenticular vasculopathy, nothing but a CMV infection. This is the calcifications along with the PDA in this baby, with the cataract. This is the PDA baby with the cataract with the rubella. You can see this classic echogenicity. Simple things we can pick up. Growth restricted baby with anemia and such findings, usually you can pick up. This baby with the hydrocephalus with the background history of associated toxo. And this is a classic baby of history. From history, you see these echogenicities. This turned out to be HSV encephalitis. So please and please correlate clinically, then do the focus, confirm that. That's what we are trying to tell you. And so simple, you can able to diagnose pneumonia as I showed you. This is every pediatrician should know the pneumonia diagnosis. No excuse for us now, because we do see a lot of pneumonia than the RDS. Most of the NICUs have a lot of people who diagnose RDS with surfactant. But if you do the posterior basal zones, you will find pneumonia. That is basically hepatization, straight sign, and associated air bronchogram. This is the horizontal scan. Always do the horizontal. A lot of people do only the vertical scans and they said, no, normal. But this horizontal scan will pick up that area very well. And that's called as the classic picture of a pneumonia. This is pneumonic effusion. Very easy to pick up. This baby, I would have missed myself, but this is on the X-ray. But this is empyema necessitans. These are the ribs. This is the broken ribs. This is empyema, and there is a subcutaneous here. So this is a classic empyema necessitans. This is lung abscess. MRSA with lung abscess. So you can able to pick up, and that's what the classification we published in the journal Newborn about the various gradings on the lung ultrasound. You can go through this article about the pneumonia and grading and severity. So I told you about the echo, I told you about the brain, lung, gut, and the liver. Let's talk about the lines and procedure in the next 5-10 minutes. You all know everybody puts this UVC, and UVC is the most notorious line on the earth. 50% time it has abnormal position. Could be liver, could be heart. This is the line in the heart, in the LA. Line always goes through RA, PFO to LA. Or the line goes to the left lobe of liver, or the right lobe of liver. This line is okay, normal position. Or this line is in the UAC is normal position. So confirm the line position. Confirm the peak line position. That's IVC peak line position. Very useful, very easy. You can able to diagnose the effusion, or you can do the thoracocentesis. This is classic ultrasound guided thoracocentesis. Very easy, very important. You can also diagnose the pericardial effusion or cardiac tamponade because of the cannulas. A lot of time, UVCs in the heart develops the pericardial tamponade. Drain immediately, baby will survive. Otherwise, we'll lose the baby. A lot of time we have noticed the ascites, again diagnose the ascites, again the therapeutic ascites. That is what we require. So every system, you can able to pick up points in your daily rounds. If you practice that daily, that is what happens. Sepsis is not like that. It has new challenges. We have a lot of challenges about the sepsis, and newer bugs are happening in day-to-day practice. We all seen now, okay, I told you that we do get a lot of outbound admissions, almost 2,000 admissions per year, and around now 10% of babies with the sepsis. But now sepsis is not limited to gram negative. We could actually getting gram positive also and fungal also. That is what is concerned now. Yes, gram negative is a major chunk, but the gram positive and fungal we need to keep in mind. So that's what the trend of gram positive and trend of fungal is going up day by day because of the rising NICUs. We all know the pandemic. So we all have seen the COVID-19, and naturally as a research I'm talking, always once you find out, do the research. We did document about the antibodies, we did document about the encephalitis and the COVID. We did say that various babies with the shock and hyponatremia and in the COVID, various articles published in basically the BMJ or the NNF or the infection, those are the journals which we published. In 23 in our unit, we have another bug, which is the Stenotropomonas. I think a lot of NICUs might have that, but we have almost 6 cases of those. And what we saw that we have a lot of babies with multi-organ failure. So newer bugs are there. We need to confirm that bugs. In 2024, I never heard this bug, and we got these Robert Murray bugs, which is a gram positive, but with meningitis. And then responding to the basically the meropenem. That's what we have, almost 32 cases, which we published in the UREX. In 2024, in Pune city, we have a lot of neonatal chikungunya. And one of them with ventilitis, encephalitis, one with ventilation, one with shock. And that's a classic rash of chikungunya, which was very high incidence in 2024. And then we have seen this encephalitis because of the chikungunya. In 2025, last year in the monsoon, we have a lot of RSV in Pune city, almost 22 neonatal cases, all require respiratory support because other babies might have been at their own places or managed by at a small nursing home or level 2 NICUs. 2 encephalitis, 1 myocarditis, a lot of them required prolonged duration. So every year there is a new bug happening in the last 5 years. Definitely we need to accept that, and we need to go ahead from that perspective. So this is what the focus has helped in day-to-day practice, and the sepsis is playing with us, but it is our role to document that. Hence, I told you research and training is very important component. And that is what we all as a clinician, we all as a teacher need to take forward. So last 10 years, all our DM candidates almost published 100 articles, lots of international guidelines, basically national and international guidelines, and we have written various book chapters. So this is what my role, which is we published in 2019 in European Journal of Pediatrics, Focus Crashing Neonate Protocol. The 15 of us, we were together for last 20 years. And the members from US, Canada, Australia, and Asia, we have made this crashing neonate protocol. Once the baby is crashing, you need to check the brain ultrasound. You need to check for the bleeding, check the lung ultrasound for effusion, consolidation, pneumothorax. Check the heart for poor contractility, for tamponade, empty heart, or pulmonary hypertension. For the gut, check for ischemia and free fluid. Very simple, very easy, and quick respond you can able to work on in those scenarios. Recently, last year, we also published the IDS and the lung ultrasound guidelines along with the Italian team. That's what we have made international consensus, and these are available freely. We also made guidelines for the framework of the POCUS assessment as the curriculum development, as the structure formation, at the measures and the process. And the two guidelines are in pipeline. One guideline is on the lung ultrasound online training plus physical training. And the one guideline is a CDH guidelines. Hopefully this year they will be out in the next 6 to 8 months. Those are the two international guidelines in pipeline. So friends, those who are interested, take this hemodynamics and POCUS in the center. I showed you the sepsis related research. You all can think about pulmonary hypertension, respiratory hemodynamics, growth restriction hemodynamics, transfusion hemodynamics, delayed cord clamping hemodynamics, aspects hemodynamics. A lot of research can be done, and that's what we as Indians can take POCUS at the international level in a better way. So it is our responsibility to take the POCUS at a different level. Lots of innovative research done by our team in the POCUS as oral versus IV sildenafil. This is the first article in the world which is published in the BMC Pediatrics. Oral sildenafil versus oral bosentan, again published last year along with Dr. Satyam. We also mentioned about noradrenaline. We mentioned about adrenaline, noradrenaline, and I just mentioned about the liver ultrasound. So think about the newer things, think about the newer innovations. Innovation is the future. We cannot say that we are doing same thing. We as Indians, we need to take that forward and then work on that one. So research is not one person, which you all know. So for us as a research, we have, yes, I do have a lot of ideas. We do design the studies. We have 5 DM faculty. They review those things every 3 monthly. We have 5 DM candidates. Every DM candidate, they do get one of the short study on the POCUS, and we do correlate with all international faculty. Of those 15 members, one of them, they do also help us. So it is all collaborations. It is all working in the future for us to improve. These are the books written by us to utilize in day-to-day practice. And most of the DM and DRNB students or the fellowship students, they are utilizing these books in India or outside the world. These are the neonatology books also we have written. Lots of the book chapters, mainly you can see this is hemodynamics book chapter or the POCUS books or Clarity or IIP textbooks. Everywhere the POCUS chapters are written by our team and taking forward. So not only the research, we need to think about spreading this knowledge. We need to forward this knowledge and take forward in the form of training. We have taken pre-COVID era, a lot of workshop, but workshop is just for stimulation. It doesn't give you idea. Hence, from COVID time, we have started lots of online sessions. Almost, you can see these online sessions of 20 countries. But we thought one innovative thing, can we transfer this knowledge at a global level by digital technology? Because in COVID, we all have started digital learning. So on 23rd March, there was a lockdown. And the 1st April, we started this global newborn health digital education by various programs called NeoPOCUS, NeoPulse, NeoModule. And we mentioned Indian Digital Gurukul System. I'm so happy to inform you that we have trained in the POCUS 800 members from 30 countries. If you conclude POCUS and Pulse, we have trained 1800 members from 41 countries. Believe me, we as Indians are good teachers. Believe me, we as Indians have a good knowledge, transfer the knowledge. That is what we require at present moment. So if you see, this is the Maharashtra map. Almost all districts of Maharashtra members we trained. This is the map of India. We have, except this portion, almost all the states of India, we have members we have trained. And this is the world map. You can see this portion. Probably, yes, currently still lacking in the Europe and the Russian countries, but most of the part, and South America, but most of the 41 countries we have reached on those areas. These are the various batches. So we started in the 2020, and now We are in 2026. This is the 10th batch. It's ongoing. Almost 800 people from various parts of the world, what we are trained. And that's one of the innovations, one of the digital innovations, what we've currently done in the world. It is not only the members from only the Asia and Africa, members from UK, US, Canada, Australia, they join because they don't have this structured formulation of 6 months course. The structured 6 months course has 55 sessions, 2-hour sessions, 1 hour is homework, 1 hour is a teaching. And everybody has to do the homework. A lot of people say, how you are teaching ultrasound online? Teaching is art. It has to percolate. It has to go to the next generation. And that is what is our theme. We published this article, and which is the first article on the online lung ultrasound training, which is published in Frontiers. And this is a backbone for now for our international guidelines, that we can combine online teaching and the people have a better improvement. A lot of people, my colleagues, those who are West, they said, no, you cannot teach online. And you will not believe, out of these 800, almost 150 members are from developed world. And they are so happy now. They're utilizing now in their practices. That is what happening in day-to-day practice. The POCUS has developed professional development, ultrasound brain. They are so happy. Cardiology, almost 70% said, yes, we are okay now. We are improving now. Our aim is to find out whether this baby at tier 2 cities of India, can I deal with this baby or should I need to refer this baby? Can I manage this baby, whether this is a respiratory cardiac, manage or not manage? That is the first important thought process. There is no pediatric cardiology. There is no pediatric radiologist. There is no adult cardiologist. There is no radiologist available. This POCUS is helping in those cities. I can take n number of districts of Telangana. I can take n number of districts of Andhra. I know everyone there. Every city, they are managed and they are doing wonderful work. That's where networking, that's where overall educational sessions are taking place. Those members, this is the story which, as the, I don't know how many of you know, that's basically the incubator is the podcast. And that's where I have mentioned about the mentorship of NICUs. That's one of the area which I have not mentioned in this one. I do mentor a lot of NICUs, almost 35 NICUs in the country plus Nepal and Myanmar. So I have mentioned the POCUS, how we are taken forward. Those who are interested, they can go through that. And that's myself. We have introduced this at a global level as the situations in that one. And I told you about the various online training in the various batches, and that's what's going on. So friends, POCUS is a future in neonatology. So I told you this is the article, you can go through that, written by our team. POCUS in neonatology in India, the way forward in Indian pediatrics in 2023. Read it, that has included all that. This is the last month, which we have written as the editorial. We published the POCUS as the whole journal, and we said the POCUS as advancing care. So what are the futures for the POCUS? Along with Dr. Yogen from US, along with the Belinda Chan from the Europe, the POCUS, we need to find out about the extended applications, check the outcomes, check the prognostications, check the quality, check the validation studies, standardize at each your unit, advanced technology, and definitely AI is going to come in the future. So definitely, you cannot say that as a clinician, oh, I don't know the POCUS. It is now become mandatory. A lot of people in tier 2 cities, those learning from 2020, now this is the 6th year, they have taken the ultrasound machine in the OPD now. And that's why they are not only in ICU, in the OPD, and that's what they are changing the scenario. So yes, I believe the POCUS is a future stethoscope for us. And I told you about the role of POCUS in sepsis. You can have a role of POCUS in various parts. You can have the POCUS in various systems. That's what is happening. So we know that the sepsis, which the hemodynamics I told you, has hypotension, secondary primary hypertension, vasodilatory shock, which is a warm shock, with biventricular dysfunction, with myocardial performance index problems, with third space loss. And as the vasopressors, think about adrenaline, noradrenaline, vasopressin, dopamine versus the pulmonary hypertension. Be careful about that. Neonatal fungal infections are emerging problems. You can think about the newer bugs, newer challenges, and heart, brain, lung, gut, liver line focus is very useful in day-to-day practice. Every day you will find two abnormalities. If you have 20 bed in ICU, you will find two abnormalities by focus in your round. It is a game changer for tier 2 cities. Tier 3 cities, you get cardiologists, you get radiologists, or you get a lot of people who are doing that. A lot of people are actually doing good work in various tertiary centers. A lot of DM centers, a lot of DRNB centers, a lot of tertiary corporate hospitals, they are working into that, but definitely that will help. As an Indian, please take research forward. Please document your own data. Please publish, because India has a huge potential. At every level, in the next 10 years, India is the future. We all need to take India forward, and a lot of great people are there in India. They are also already working on this front. But if you are younger, work on that. Take forward one of your area, because there are a lot of neonatologists are there. But once you do the develop research, that will happen. So friends, work for success, that will make a master. Yes, we all want to success, but work for satisfaction. Whatever you do, select one area. I'm not saying only select focus. Select one area of your neonatology. Take that international level. Whatever area you are defining, that area, your name should be there in the world. Don't think only Telangana. Don't think only Hyderabad. Don't think only about India. It should be international level, because Indian people are so good. We all capable of that one. So friends, this is what I wanted to cover in the almost 45-50 minutes. With this, I think I'll stop here. And any questions from any member, happy to take those questions. Anybody has any points? Whatever the data which we have collected, we published, which I showed you. But everybody has different angles. Everyone has a different scenarios. Outcomes are great in India. We are talking from 23 weeks now, and a lot of units are doing good work. Definitely, it is a time for all of us to think one step ahead, which I all think the research, which is still a lot of scope. Only few centers are doing, which we don't want. Lots of centers should do. That is what we all think. Thank you.
Thank you, sir. Thank you, sir. Thank you so much for the beautiful talk on neonatal sepsis focus and the amazing training and research work you've done in your unit. Dr. Pradeep Suryavanshi, sir, is known for his excellent presentations. The most important and amazing thing what we observed over here is like what the evidence or data has taken in his talks are entirely from his unit publications. And you can see a number of publications by the DM students from his unit, where this took the Department of Neonatology of Bharati Vidyapith into the highest level when compared to any other institutions in India. Thank you so much for that, sir. It is a very wonderful, amazing presentation to be uh, uh, we have gone through. And before going to the question answers, may I request Dr. Vijayanand, Secretary NNF Telangana, to have a few words on this.
Yeah.
Dr. Vijayanand.
Sure, sir. Thank you, Lingareddy, sir. I acknowledge the presence of President Dr. Nirmala Madam and Chairperson Dr. Surendranath sir and Treasurer Dr. Tejo sir. Pradeep sir, as expected, it was an excellent presentation, lucid, clear, and great work. I congratulate you the sheer amount of the work. कभी कभी विचार में ये आता है कि अरे ये आदमी इतना कैसा कर पाया, how did on earth a person can do so much. I think as you rightly said, there is a will, there is a way, and you are such an inspirational person. And I first listened to you in 2013 New York On, and I've listened to you several times afterwards. And you always inspire the not only young minds, the oldies like me as well. By the way, I'm not. So so I have a few things to comment here about the back to the focus and the neonatal sepsis. And yes, focus has become routine in the neonatal units. And but bear in mind, every skill is as good as how much you learned, how you know how to interpret. So there are limits. I do have focus a little bit. So you need to important to know that what you don't know, and any focus, it's obtaining the image, optimizing the image, interpretation the image. So one of the things we did in the clinical practice, we always do try to, is obtaining optimize we can learn, and for interpretation we have experts as well when we ourselves is not clear. That is essentially telemedicine. I'm sure Pradeep sir would receive 101 images every day. Sir, what it could be. That's how we all learn. So don't forget uh, making a phone call or dialing the phone a friend, whatever, or mentor, and realize the limitations. So as a beginner, and the beginning of at a different skills, so you are not sure whether it is you can't, or it's because it is doesn't exist there in that baby. I still remember one of the my course in cardiac unit, sorry, neonatal unit I was doing. I was a cardiac registrar in Bristol in UK, that I could not find pulmonary arteries. And the consultant came back, the cardiologist said, well, Vijay could not find because there are no pulmonary arteries there. So that's always the doubt. So bear in mind the limitation, but as you do more and more, it has become a routine, and use judiciously, and don't forget your clinical medicine. Okay? It's a supplement. Every tool which comes is a supplement to your clinical medicine. It should be put all together and seen. But and sir, as always, you have put it so lucidly, so clearly, and you taught us not only the focus but also the basic, simple principles in such a amazingly lucid way of using the inotropes. And I know you also do a talk completely on inotrope. We may wish you to bring you back for that. And we made it so simple, and that's very useful for all of us. Then, but I have a wish here. My wish, it is actually when I looked at all the focus images you presented, it is disturbing and distressing to such a bad sepsis consequences and sequelae. Okay, no wonder 217 Dennis trial said 50% death in culture positive sepsis, 25% in culture negative. That is only documented data, and we do know babies come and die in front of us. I wish we'll not have any such data in future to present or publish any papers. And I know it is a good wish, and probably we will be presenting and publishing and researching more on predictive models of sepsis through focus. I'm sure you are working on it. I'm sure you will be publishing in a year or two. And that's the wish I have. And as a neonatologist, and as a pediatrician, the top priority is prevent infection, if not early detection, effective treatment, and let not our babies go to that level of end organ, such a bad sequelae of it. Hopefully, we don't have to see these images 10 years down line on. Once again, I congratulate you, sir. I thank you accepting our invitation. And we can't have any better start. We can't have any better batsman than you to start our webinar series in a such a dashing and 2020 way. And with but though you present in a 2020 way, it was a full feast of 5-day cricket test match with all the flavors in it. So I once again thank you. I stop it there, and I thank all my NNF team from Telangana state and Lingareddy sir for taking this. And this is our first formal educational activity of the year, having oration the day before in our installation ceremony. I stop it there. Thank you.
Thank you.
Thank you very much, Dr. Vijayanand. I don't know whether it is appropriate here or not, but I'll tell you one thing. how the person, Dr. Pradeep Suryavamshi, has become the icon of focus throughout the world. He one day told me how he was struggling to learn focus. His teacher asked how much commitment and like dedication from him to teach focus. I'm remembering that conversation. It happened in Pune when I visited his unit. Thank you very much, sir. Any questions,
Lingareddy, one comment.
sir?
One comment.
Sir, Chapan.
So I should thank you for calling me before this webinar. In fact, really, I mean, it was like a 2020 match. I saw the Suryavamshi century that time 2020 match, and there's another Suryavamshi who scored century in 2020 match. I mean, thank you very much for
That
just
another
reminding me.
Suryansh is only 14. I'm 52. So
Sir, I'm 67.
I know. I'm just
Uh,
kidding.
it's a
Sir, we are
wonderful.
always comparing, sir. Both Suryavamshis, we are
So,
always comparing.
no, Lingareddy is also a younger Suryavamshi version of.
I know.
And I thank Nirmala for choosing a fantastic speaker. I mean, I heard first time really, and it's amazing, sir, the amount of work you are doing. And now I got some ideas what the thesis work our DNB students and our
Yes.
fellows should do.
Of
Now,
course.
thank you very much for your motivation.
Yes.
It was a wonderful talk.
Thank you.
Sir, one question. You have
yeah.
done a lot of research and focus is the in thing now because it's bedside. It helps you in managing the newborns with various, in the NICU. But when you had looked into from the outborn, what were the risk factors that you have commonly seen, which in the community, if you bring about awareness, can prevent such a extensive sepsis, so much of fungal balls and so much of abscesses. So, what was your study? I mean, you had done a lot of
My
research
thought
about
process.
inborn and outborn.
I'll just tell the other things. I conduct another program which is called Neopulse to train the pediatricians of a tier 2 cities, which is called as less is more. What is happening actually? Everybody wants to start NICU, and I'm not opposing that. But when you start NICU, please think about proper infra, proper human resources.
Absolutely.
And what we have designed 10 points, because that's lacking. Everybody wants to ventilate. Everyone wants to give lots of antibiotics, invalidant TPNs and all that. So we requested them, you join those things, not to ventilate more than 3 days, not to give antibiotics more than 3, not to use TPN more than 5 days, at least have a good number of nurses, and don't manage babies less than 1 kg. You can please have in-house delivery to those. That's what I did mentorship in the periphery of Maharashtra. Because unfortunately, everybody says, I have managed 800 gram, I'm doing good. Everybody says I'm 1 kg, I'm doing good. 1.2 kg, I'm doing good. But unfortunately, they don't have a backup as a team. Now, all of you are working in a team. What I presented is not me, it is a team. I have 5 faculty, 15 DMs, 100 nurses, 12 MD resident, then I'm managing 60 bed NICU. While a single hand person managing 12 bed NICU, 14 bed NICU, 20 bed NICU, invariably it is going to have a problem with the infection. Whether we agree or not. They don't have choice. They don't have choice because the patients are not coming immediately. Out of 100, 90 babies gets cured. 5 or 10 babies don't get cured, they come to us. Last 5 years, I have seen 28 babies of fungal babies. I have seen ROP requiring laser. In my unit, not a single baby required laser, but all outborns of 12 babies required laser. So what type of patients we are getting now? Cardiac babies, fungal babies, gram-negative bad babies, or ROP babies. That side of babies we get as outborn, because as a medical school, again, we, as a Maharashtra, almost 12 districts we get referral. But my wish is that, as Dr. Vijayanand said, not to see these babies. But unfortunately, SNCUs, we don't have a lot of equipments, resources, human resources. Doctors are not there, nurses are not there. It is a lot of management issues are there. But things are improving day by day. We have to be positive.
Yeah.
Let's accept the things of India in 1990s, 2000, 2010, 2020. We are getting better day by day.
Yes.
But yes, I agree. When we present, it looks very bad. But everybody has seen these cases. And
That's the reality.
Nobody wants to present because, oh, what will they will say? Such type of patient I have. But let's accept sepsis is there. I cannot deny it. I don't have sepsis. Even though I have such a big unit, we have family-centered unit. Every baby, 1 cubicle we are given, like an adult ICU. Still, I have sepsis. Because every 2 years, nurses change. They all go to Middle East. So I cannot change that. But we have to prevent. That is in our hand. What the Vijayanand said, that we have to prevent, we have to teach, we have to train. And let's see that NMR came down from 40 to 20. So that's a good for India. And it will change. It will change. Once we say that milk, breast milk, that is going to change. So I feel that this is what another area which I concentrated. Monday to Saturday, Monday to Friday, 9 to 11 p.m., I conduct all training. Linga Reddy was behind me for last 6 months. I said, Tuesday is my teaching. Sir, please reserve one Tuesday. Please reserve one Tuesday. And I told my team members today of a 10th batch, please excuse me. I was his examiner and his son is my now student. I have to just say once yes to him. Otherwise, don't take me wrong, I have stopped attending conferences because a lot of members are outside the hall and we are inside the hall. But now in digital education, which I believe now, I saw today, your Telangana group has 100 capacity. And I got messages, sir, we are not able to join, we are not able to join, we are not able to join. So people are interested joining from home, avoiding time, avoiding the travel problem. So that's what I'm saying. I'm happy. We need to, all of us, take forward. Every society is doing that good work. Every team is doing good work. Everybody wants to teach. That's a wonderful thing happening in India. I already said, Indian teachers are the best teachers. Please understand. I have now talked with every country, with every person. We are very clear-cut about our knowledge. Only thing, we are not able to expose outside our own data, which is coming now day by day. Now, let's see Tejo or all these people, they are doing that way. So eventually, after 10 years, people will say, wonderful, wonderful, wonderful. Things will change. That is what we have to work on that. So that's what I said.
Thank you,
Very
sir.
well.
Thank you so much. If there are no questions, may I ask Dr. Tejo Pratap, the treasurer of NNF Telangana Jharkhand, to give a vote of thanks.
Of course, few comments as well.
Huh?
Okay.
Few comments.
So I think everyone has shared the impression on how the sir has taken the lecture and how sir has evolved in the focus also from the beginning to now. I can only look at two aspects, sir. One is that you spend a lot of time in teaching. That's one thing that I always admire you in the thing. And that again give the word that teaching is the best way to learn also. That's what I always believe. And you always show us the same thing. The more you teach, the more
you learn.
become better and other things. That's an inspiration to all of us. And I hope other people who are listening also, they will start teaching from there also. Second thing, I can only say that the inaugural seminar on tiny lives and big insights, I think we got very, very big insights on the same thing. And one is that not only the subject, and second thing is that in terms of mentoring and then teaching, and then what is the future ahead, especially for the neonatology, and then how we can become contribute to the society. And sir used the word India almost in the last 5-10 minutes multiple times. I was very happy about that. And then so many, I agree, sir, so many papers are coming out now, and then people started looking at our data also. We are publishing our data, and then good articles, and we are all part of many multi-center studies also. And then we are trying to collate the data and other things from nook and corner of the country, from different aspects and other things. But still, I think there is a lot way to go. That's what I can say. Maybe I think, Dr. Nirmala Madam, I think one suggestion that we can try to look at is that can we try to collate some data from Telangana NICUs also. Even if it is basic, I think we can try to keep it as monthly data, heuristically, whatever the way they want to. We do not want to keep much, maybe 10 parameters or 15 parameters. Let's see, and then see, we'll, acknowledge them. And then second thing is that we'll not keep anybody's name there, and then it's only data practice and other things. We can try to anonymize the data, and then try to see how best we can try to help the society and community in the Telangana. That's what I can say. And I would like to thank you, sir, for coming and giving us a great lecture. And then we have Dr. Surendranath sir and Lingareddy sir, who are our committee for this program. And then I also acknowledge that Nirmala Madam and Vijayanand sir and other senior members who have spared the time today. And then the students also. I hope you all go with a very good feedback, thought process in the night, and then a lot of insights to implement in your practice. And then I'm hoping that more and more people will take up these sort of responsibilities and then excel in your own field. As sir said, that take up one area and then go to the highest level wherever it is possible. So we should be on the international platforms. We should be able to talk and then tell us about our data honestly, and then take the feedback and then improve on our side. And then that's what I can say. Thank you once again, everyone, to attend. Thank you, sir.
Very well
Thank
said.
you, Dr. Tejo. Let us conclude the meeting. We'll meet in the next month on the last Tuesday of February. Thank you, one and all. Okay.
Lingareddy sir.
Sir.
Yeah, I've just posted in the chat box tomorrow session in the afternoon about the clinical meeting. The first one is online. 2 cases are there. And of course, we posted in all the online platforms as well. So the journey of learning continues. And with a very good opening batsman. Thank you, sir.
All
Good
the
night.
all the delegates who have joined in can join for the clinical meeting as well tomorrow.
Yes,
Thank
ma'am.
you. Thank you.
Yes.
Yeah.
Yes.
Good
Okay.
night.
Good night.
Good night. Good night.
Jai Hind.